Good morning, everyone. Thank you for being here. I will introduce the next speaker, Dr. Chrestian. Started in medical science in France, continued in Quebec. He has a degree from Laval University, involved in adult neurology and changed for pediatric neurology. He came to Montreal, where he completed his education in McGill University. He's passionate for neuromuscular disorders, and he continued to the Sick Kids Hospital in Toronto under doctors Vajzar and Dowling, experts in pediatric neuromuscular disorders, and Grace Noon also. He is a staff member of the pediatric neurology team of Quebec City with his subspecialty in neuromuscular disorders and neurogenetics. He's back in Quebec. He has some 10 publications in famous journals and active in research in pediatric neuromuscular disorders. He will talk about spinal muscular atrophy, and then Aimez and Fournier will talk about their treatment with their daughters. Thank you. Thank you very much. In fact, I am replacing Dr. Mariam Mouskouri. She would have been an excellent presenter. I didn't have her presentation. I tried to improvise. I learned that there was a simultaneous translation, so I will do it in French instead of English. We will talk about spinal muscular atrophy, a larger spectrum, but some specific points that I will be able to talk to you with the audience here. And I will talk about distress, hope, and struggle. With the testimony of Joël and Leonie, it will be very clear. The objectives is to understand the clinical and genetics of spinal amyotrophy, SI, standard of practice, the therapies, and the voices, whether the roads, the pathways, or the voices of the future, voices of two families. We will see the AS briefly, the actors in drugs, the key points in the new practice guide published in 2017. I'll say a few words about other therapies and the place of INESS in Quebec in this whole tragedy, I can say. What are the other options that are left, and also the daily life of families. I had honors for presentations by Biogen. That's my main conflict of interest. What is spinal muscular atrophy? It's a neurodegenerative disease. It's a recessive autoimmune disease in line with deletion of SMAN1, which is survival motor neuron 1. It's called also 5Q-SMA because of its location. So it was described in 1891. The prevalence is not that high, depending on the literature, 4.1 or 10 on live birth. Cause is caused by its genetic disease. How does it work? It's a degeneration mainly of the lower motor neuron. It's not a pure motor neuron that is affected. So the cells that go beyond the laser doesn't go on. So it will give this nerve going from the spine to the trunk here. We see that our expressions are the MNI. So type 1 are babies who will have hypotonia, muscle weakness with in no lower members, and it will be generalized over time. It will evolve, and the speed varies according to other factors. The key element is the tongue fasciculations. It's interesting for clinicians, can see it immediately, and absence of reflexes. For type 1 and 2 or 3, you see many polymyoclonias. That's in later expressions. Diaphragms and bulbar affections are a key point in the evolution of disease, and the severity goes from 1 to 4. It is divided into 4 or 5 classifications. 0, it's anecdotal, it's neonatal, when the baby is born, multiple contractions, and they don't survive after 1 month. What we see more often is 1 between 0 and 6 months. The average lifespan is they don't live beyond 2 years. Type 2 and 3, it is more subtle. Age can vary between a few months until even a few years, a year and a half and a few years after expression. And what happens, it's a myopathy. Sometimes it can be delayed. It is a very rare and light or slowly progressive and falsely diagnosed as SMA or SLA. The usual diagnosis is the following. Is it a spinal myotrophy? For type 1, directly, as soon as we have clinical elements here, the absence of reflex and fasciculation of the tongue. Type 2, 3, 4, since it can be confused with amyopathy, the MG can show that there are nerve or neuron or nerve problems than muscles. It is rather exceptional. Given it is easy to see, we can observe rapidly without waiting for results or even an electromyogram. So it is done in St. Justin Hospital in Quebec, and the result can come within 2 weeks. We can ask for dilation. It's not complicated to confirm. Very often how it is presented with type 1, it's the trunk here, like a bell-shaped thorax. And before, when we would do a muscular biopsy, we had atrophy here and angular atrophy, atrophied fibers with nerves and not muscles. And there are other forms of SMQ. It's called non-5Q SMA. There are every month 7 or 5 to 8 new genes that appear from SLA, juvenile SMA, or HMN also. To understand well what is going on with theory, we have to understand genetics. The main gene that is affected is here, the chromosome 5, the second gene on the same chromosome, not too far in terms of distance, SMN2. The SMN2 produces in most cases a protein which is truncated and non-functioning. So there's exon 7, so it is skipped. So once in a while, there's a natural phenomenon of exon that is skipped here, and the part that should see that exons are not transmitted, they're transcribed, there is transcribed. So we have a full length protein, which is the same as the one that is transcribed. Patient with SMA type 1, 7EX7 are missing quantity of protein. SMN drastically decreases because it depends only on SMN2, 10% less than the usual protein. So it's not enough for the survival of a motor neuron health and survival. So the clinical presentation of these patients varies with a number of copies of SMN2 in general population. In fact, you and I, we have a very number of SMN2 copies. Some have 0 FSMN2, but a perfect SMN1, which is cocky. And some have only 1 copy of SMN2 and 2 copies of SMN2. Presentation of SMA varies according to the number of copies. In general, 2 copies will give a type 1 early type, but it's difficult with 3 copies. So we have a hard time predicting, and there are other factors contributing this evolution. The prevalence is important from this heterozygote deletion, 1 on 40 or 1 on 60 people. Finally, the SMA, it's a deficit of SMN1. 98% of patients, it's a deletion, homozygote of exon 7. Only 2% of patients also have a mutation. It happens that there's a patient with a classic SMA, but there's only 1 mutation. We have to sequence the gene and see the mutation. And now the clinical presentation can vary. I added on the bottom the number of SMN2 copies. This number of copies will explain more or less acute or gradual progression. So number 1 between type 2C can vary. Some can have only 2 copies, some 3 copies, but there's a good correlation in clinical presentation. This is what Dr. Oskui wanted to talk about. This is an important element, so I took up this part here and take a little bit more time. The SMA is not only a neurological, it's a multisystemic disease. First, in the heart, I'll go from left to recently publications for patients with type 1 SMA. We saw heart anomalies, intraventricular communication, even arrhythmia, or severe bradycardia, and endocrinial disease, I'll say early, with diabetes, intolerance to glucose, hyperlipidemia. It is a disease with a respiratory disease major, and this is really the pillar of treatment. Digestive disorders are important. This is a pillar of rehab for these children. Given a not well-developed muscle system in the abdomen, there will be a difficulty for food, aspiration, and also constipation. And very often they complain about fatigue. Always a lot of fatigue. This word comes up very often. Is it in line with lower ventilation, hyperventilation? Or consumption of energy they have to use on a daily basis to move around and to make efforts, and only respiratory efforts. And bone and orthopedic disorders, scoliosis, and contractures. In fact, recently the evolution of treatments that appeared really shifted the paradigm for treating SMA. Before, until recently, it was a palliative approach. Even in Quebec, we were quite resilient with these patients. Most of families didn't want to be part of research projects because they said that anyhow it wasn't worth it. Then we had a palliative treatment and aggressive treatment. For food, respiratory, and other practices. A guide was published recently in 2017 by SME Care Group, and it was so important that they divided it in 2 parts. The first part was mainly about rehabilitation, orthopedic, and nutrition care. Second part, very interesting, on respiratory treatments, pulmonary treatments, supplements, immunization, and that was important also, the acute ethical part and palliative care. Why being aggressive in treating the disease? Because SMA is a multisystemic disease, and genetic systemic and changing therapies will evolve according to the disease, and we cannot have children that will develop systemic and it's not neurological problems, because we will change the neurological prognostic of the children. What about rehabilitation? What is important is that to facilitate the care of all people, since it is a multidisciplinary, we talk about physiotherapy, occupational therapy, neurologists, physiatry. And we use the clinical classification type 1 are non-sitters, type 2 sitters, and type 3 are walkers. For rehab, we see that it is an observation and treatment that is quite aggressive. We are interested in prevention, posture, preventing scoliosis, dislocation of hip, avoid this formation of thorax, because it will bring pulmonary disorders, contractures. It is very often painful. An important point for non-sitters, sitters, and walkers, standardized assessment. And this is a major change in neuromuscular diseases, because since we have more and more therapies and genic and costly therapies, we want to know the impact of therapies and be able to validate their efficiency. It will require a standardized assessment. There are very nice standardized scores in literature was put in place by Chopin and the Ening. Scores are motor development and functional scores that are can easily be implemented. For non-sitters, we mainly want to optimize the respiratory functions and also clinical and neurological functions, and minimize and facilitate tolerance to positions. For sitters, this is basically the same objective, but also a focus is put to prevent scoliosis. This is a real struggle to see that scoliosis develop as late as possible. I'll tell you why. And also contractures for positioning. It's very important for postures, and we want to maintain mobility and efficient functions. Now, for walkers, of course, the evolutions is slowly, but the issue is about mobility. We want to focus on mobility, focus on the functionality of patients. Same thing to promote articular amplitude, prevent scoliosis, and to see that respiratory functions are efficient. So positions, orthesis, stretching, and promoting mobility. Now, for orthopedic disorders, this is where things change recently because of treatments, nursing. Scoliosis with orthesis will be difficult for accessibility treatment. We want to prevent. For even before non-sitters, children, we would put them aside, and we wouldn't look into scoliosis. Now, with this new guide, it says that we have to monitor that, met them in a sitting position, prevent scoliosis, which is very important. For sitters, type 2 and 3, the issue here is major. We have to be very, very aggressive, prevent scoliosis below 20 degrees of angles. We can observe. This is what we see we have to see every 6 months, or during if the degrees evolve at more than 10 degrees, we have to put orthesis or do surgery when the angle is more than 15 degrees. There are different techniques that are appeared that will allow at the same time the growth of the child, the magnetic rods that are being seen into. We want to prevent fusion as late as possible and objective mobility. If we put rods on a child, the spinal cord will rigid, and it will not be helpful for mobility. So the fusion of a spinal cord will wait after puberty or beyond 12 years old. For walkers, same objective. The current issue is to choose the material. Will we need to have orthosis for the patient, treat scoliosis if it's severe, to allow access for future therapy? Nutrition. The first key point in treatment. Very often it was left aside, and a study was interesting, and I give that to all. It's a protein of milk, so that patients don't lose weight. We want them not to gain too much weight, because overweight is not very good for mobility and not very good for respiratory functions and scoliosis. For non-sitters, we are now very aggressive. We consider deglutition, fluoroscopy, video fluoroscopy, and we suggest to put a nasogastric tube to maintain appropriate nutrition and gastrostomy. For sitters, now it is an assessment that is recommended every 6 months for dysphagia. Same objective, we want to prevent early dysphagia, maintain nutrition. It is suggested to have a nutritional follow-up and level of albumin, prealbumin, other affecting other parameters, so that nutritional aspects are optimal. For walkers, same objectives with a focus specific to avoid any obesity. It's major. And a child who is obese and a walker and will lose that function. It happened for some patients with a nutritional treatment, a very tight treatment. Walking can be maintained for a few months or additional years. Now it is recommended to follow up for glycemia, develop an intolerance to glucose, and sometimes diabetes. In the future, with future therapies and the shift fatal disease now published that will survive a few years, we will need to follow this, and especially for diabetes. It is recommended for non-sitters, and it is to have a regular nutritional analysis every 6 months, acute monitoring, and also for those with respiratory to see that the calories are sufficient, and to treat constipation early, and to check the bone density, avoid osteoporosis. It is also recommended to have regular follow-up for anthropometric size, weight, body mass index, and follow the vitamin D and give a supplement and calcium to prevent any problem of osteoporosis. This is the major point here in the treatment change for SMA. Respiratory treatment, major change in gay nights. In Quebec, we were already proactive. Others were proactive too. Now we ask us to be even more proactive. Dr. Vanisowski talked about polysomnography, polyventilation, vital capacity. And now already we have to assess the patients. Am I cut off if they start to be weak around the neck area? If there are no symptoms, I like to refer in pneumology and polysomnography to ensure that patients don't have sleep apnea or hyperventilation. Beyond 40% of vital capacity, we have to use a BiPAP. All these aggressive treatments take into account other parameters, food difficulties. I talked about the neck weakness. There's often nutritional weakness. They say it takes an hour to swallow, to walk. It takes a lot of energy, but is very careful. Probably means that probably he's due for a non-invasive ventilation. Non-invasive ventilation continues below 20% of FVC. For respiratory assessment for non-sitters, it is very demanding for the team. An assessment every 3 months at the beginning according to the patient's evolution for non-invasive ventilation. For non-sitters, assessment every 6 months to assess ventilation function as spirometry, and also early signs of cephalia, fatigue, dizziness, to have this assessment according to the accessibility of walkers. Same principle. When they are able to walk, we want to maintain their functional pulmonary function and also capacity for expectoration. There are techniques that are put in place and that we put in place even for non-sitters. And what are early respiratory functions to consider rapidly to be able to remove secretions, oral suction for non-sitters, to teach that to parents and to bring that at home for ventilation, non-invasion ventilation, and ensure that the gastroesophageal reflux is assessed because it can lead to respiratory disorders and infections. For medications, treating early with a bronchodilation for non-sitters and sitters, if there are signs compatible with asthma, and also vaccination. Strongly recommend to vaccination for influenza every year, to update vaccinations and recall for pneumococcus, and for children also, for synergists, and for non-sitters. What is interesting on this guide or guidelines are a hospital acute care. I didn't cover every part of these care. We talked about respiratory care at home during transportation and in hospital. What we have to remember is that we ask that we are aggressive as soon as they come at the ER to have non-invasive ventilation as soon as they come here. So ventilation right away, and also to remove excretion, treat aggressively all infection. It is recommended to talk with parents about their wish, since we know that they will be intubated. But once they are intubated, we have to treat the pneumonia and secretions. We have to take their time with this. Sometimes we have to do early extubation. We need to be sure that they are ready when we do extubation. We don't want to use it again if this fails. We will consider post-extubation to use a ventilation. And I want to take the last few minutes and give you a brief overview of the treatments and therapeutic evolution for SMA. Starting in 1990 with supplements of Carnitine and also Rilutec and salbutamol gave more functionality to some patients. In 2014, explosion of cytokinetics and sinusin, all the fish, moonfish, farfish, and eroxime, avix. Treatment strategies are based on the fact that we know the fetal pathogen of the disease. We even still discover more. And we try to increase the production of SMN protein with valproic. We thought maybe working on muscles to reinforce contractibility with cytokinetics and salbutamol. And we wanted to use what nature offered. We have a second gene, SMN2, able to produce the same protein. It is only a problem of a small mutation that gives a selective episode that we cannot transfer the protein. If we want to made silent this episode zone to allow the transcription of the it's Nucinifes and all the fish treatments. Ideally, we have to replace SMN1, the missing gene, with AV6 and other alternative pathways. Reinforce productivity of SMN. I have patients with vimal. I think it reinforced fasciculation. Some find that it was reducing fatigue. It's no impact on muscles, but it was reducing fatigue and improving energy. Cytokinetics in phase 2. And the antioxidant aspect, we notice that mitochondria, which is the energy plant, is very important in the disease of motor neurons. And oleoxime, which is an oxidant to avoid free radicals appearance. And there was a positive in terms of maintaining all the type 2 SMN. There's a type 3 for subgroups, those who degrade rapidly. If we want to induce a transcription of SM2, the approach would be this small mutation that could give this message to make it silent. It is the antisense oligonucleotide. Many benefit from that therapy. Dr. Krebs-Corbett talked about this. And it's the main approach in nusinersen. The complete transcription of the SMN protein through SMN2. As I said earlier on, it is important to have standardized scores if the child is part of the next research or benefit from the treatment. It's important to assess the treatment of the treatment in government. They will need objective data. Many scores were validated and are regularly used. I'm very happy because I learned that at the RDPQ in Quebec, we will use this score with SMA patients. A few words on 3 studies by nusinersen. Studies that are the pillar of this medication in the CHERISH study focused on SMA type 2 and 3, published this year in January, February. And in 15 months, in fact, the study was stopped because the primary endpoint had been met. Patients treated on nusinersen, there were 4 points in aberrance and Arrowsmith, so that's against the natural evolution of the disease. It was very interesting. There are very few side effects related to the medication since it's given by punction, back punction. And very impressive in lumbar punction. Skip. Oh yes, NDIR. NDIR is the pillar of this treatment, where nusinersen was approved very rapidly in U.S. and Europe. Phase 3 ended early because of the positive results with a primary endpoint. It was DC on permanent ventilation, 16 hours per day. The difference was important, major. It was very impressive, though. Most patients, in fact, even all patients included in the study, none died, which means that we go beyond the natural history. What we noticed in the subgroups, the better it was here. That's interesting. I'll get there. To continue and collect data, people who were part of CHERISH and NDIR were recruited. Even those that were not important, they were recruited for that. It was open labor. And for NDIR, after 30 13 months, it was even better not to give the placebo treatment. The patients were transferred. The Nurture study for all patients, pre-symptomatic patients, either it was a family history or we diagnosed the patients, and we would notice very fast that when nerve is done very, very early, the development evolution is very fast. They can even sit and even walk on their knees and hands, these children. So it is nusinersen is very well tolerated. Side effects with PL, we give 4 doses at the start, and the side effects are related to the natural history of the disease, mainly aspiration. Now it needs to be approved by Health Canada for all types of SMA. So it has been approved, I would say, and we're very enthusiastic. The medication for type 1, for how long? It's a bit of stress for many families. What about type 2 and 3? For type 2 and 3, we waited for the confirmation, and we were a bit surprised and disappointed, families and people, but they recognize the clinical value for SMA type 1 based on NDR study, but they say there is not clinical value for type 2 and 3, despite category 1 study done with a positive endpoint. Finally, it was recommended not to list that treatment on the health insurance in Quebec. So that's a major problem, because in Quebec, I cannot talk about the rest of Canada, but insurance refuse to cover this drug because it is done in hospital. But in the law, everything that is done in hospital should be covered by the hospital. Now, it is a major problem because, in fact, we found alternative ways like private clinics where the lumbar puncture can be done because the hospital doesn't want to give it because it's not covered by their budget. Cost is an issue. We have 28 patients that can contribute. It's a quarter of the budget of the pediatric hospital. So, of course, costs are not acceptable. But at the same time, it's about the cost of the medication, but the procedure, it's lumbar puncture, sedation. In fact, the frustration is that probably teenagers, young adults will be able to give them in private clinic for young children with sedation and so on. It's not easy to find a private clinic that will be able to face that risk. So there's an ethical and medical issue in Quebec. The other options is to replace SMN1 with Avexis 101, which is an adenovirus, which is reduced, where we packed the double arm of a DNA. It's an IV, an injection once. We don't know how it works. It can work for 10 years. Figures were very impressive. 10 on 12 patients after injections ended up to have a CHOP intent of higher than 50. 9 on 13 were able to sit without help, and 2 on 12 had a normal score, a score of 64. They had type 1 SMN. So the question is maybe it's a preconception or prenatal diagnosis would be ideal. The question with Avexis, since it's an adenovirus, there's a risk for an immune reaction after a second injection. The result was impressive. 60% of patients didn't have any BPAP, which is against the natural evolution of disease, and none needed an ongoing ventilation. Even nutritional support was impressive. 8 on 12 patients were able to speak. Now, the modern portrait of the treatment for SMA, it's a multidisciplinary approach with many approaches at the same time for the same patient. Now, finally, what about the future, the evolution of the patient? We don't know. With this type of treatment, with the treatment that changes the life of patients, will we need to change a type 1 that will modify it towards a type 2? Will type 1 will skip to type 2? Or will type 2 have a normal evolution? We don't know yet. Future will tell. This is why research is continuing. The open label study will give us the result. Just to show you the list of treatments, the various approaches that are used in the cell node for ribonucleoprotein, and the neuromuscular junction, which is important and modifies spinal with ubiquitin, mitochondrial, everything which is endocytosis. Many avenues that are very promising, even the statins used in neuromuscular and the other diseases, a whole list of studies that are in preclinic phase or phase 1 or 2 could be additional elements in our therapy. In closing, conceptual diagnosis is possible recently in Quebec. The NIFT is the analysis of fetal DNA through the mother's blood. It is possible to have a few cells of the fetal DNA. It would not be complicated to add that in diagnosis. Maybe in the Saguenay area where there are diseases, maybe SMA could be the 6th disease that could be analyzed before conception. It is better to see that we bear the fatal disease than having a child with that disease. SMA is a neurodegenerative disease, but is also a multisystemic disease. And it's not about that. Many systems are affected. The survival depends on respiratory and nutritional status. There are many evolution in the treatments, nuisance, the fish because, and protection by SMA modifiers. Will it be a combination therapy? Maybe. If we understand the ethical issues related to treatments and especially the social and economic issues. Thank you.
J'aimerais laisser la place pour le témoignage justement de Joël Vignola.
There will be a testimony of Joël and Melanie. They will talk about their daily life.
Good morning. I'm Geneviève Fournier. My partner here, Mr. Vignola. We are in the Neuromuscular region, but we are also parents. A 7-year-old daughter who has type 2 spinal muscular dystrophy. Lucy Nursen. She started the clinical trial in September 2014. At the beginning of this clinical trial, 1 child out of 3 received the placebo. During that clinical trial, we didn't know if either our child would receive placebo or not. Before beginning the clinical trial, we had a lot of questions and few answers. We didn't know what side effects there would be for previous studies. We didn't know either the effects of the medication. We were totally in the dark. The administration is through intrathecal IV under anesthesia. There can be additional complication during the intervention. Had a lot of questions, a lot of worries, not many answers, but we still decided to go forward for Emmanuel's well-being. The first part of the clinical trial, as mentioned, was a double-blind study. We didn't know if either Manuel would receive the placebo or not. At that point, she did not make a lot of progress, but she did not lose what she had acquired previously. We constantly wondered, did she make any gains or not? Sometimes we felt yes, sometimes we were skeptical about it, but we didn't know. Also, we didn't know what effects it had on previous children in their previous studies, so we didn't know how it would evolve of type 2, such as Emmanuel, with this medication. And also the professionals could not confirm whether she had placebo or not. At the end of the study, there was no progress. She did not lose any anything acquired, but there was not much progress. We hope that she didn't receive the medication because we still had hope that she would progress thanks to medication that would then follow. In the end, we heard that there would be a second stage of the clinical trial. At that point, all children would receive the medication, but we had to wait the third injection to know that Emmanuel truly had received a placebo. She was that child out of 3 who had received placebo in the 18 months of the first part of the study. First, we were feeling more comfortable because there was progress. But then frustration, because we said we just lost 18 months, especially because we live in Rimouski, though we had to go to Montreal, lots of interventions for a placebo. So we say 18 months of unrealized gains that we could have made. Also, we know another child at the Children's Hospital. She right away received the medication and she has made a lot more gains. So slightly disappointing, but we know that at least now we have medication and we will go ahead and hope that Emmanuel will get better. What we wanted is not only, we hope for a lot of gains, and we hope also an increase of her motor functions, motor skills, an increase in autonomy. And a type 2 child necessarily does not have a lot of autonomy. I'll say a few words about this later on. How we experience the clinical trial. As mentioned previously, the medication is done through with a slight anesthesia under intratracheal injection. The first intratracheal injection, we had to stay 24 hours to monitor Emmanuel's health, to see if it was stable and to see if she would react positively to the medication. Then, every 2 months we have an injection, and now every 4 months we go to Montreal to receive the Spinal injection. Through that time we had appointments, physical therapy, specialists. I oftentimes, at least once a month, for a few days I had to stay in Montreal as part of that study. Since the beginning of that study, Emmanuel needs to be away from school a lot, and we also need to ask for days off because we are both nurses in an emergency setting. And when you're health professionals, it can be hard to take days off, and we had to make a lot of sacrifices for Emmanuel to be part of this study. The whole family, actually. Ellie is also an 11-year-old child, and he also had to make sacrifices for her to be part of the study. Vacations, we try to find moments for appointments, so vacations were spent for school making up for school time lost and etc. This was a very demanding moment, especially for Emmanuelle. She has to want to be going through the interventions, the appointments. She had to go through all of this. She oftentimes said she was tired. She was tired of also traveling from Rimouski to Montreal and undergo several exams and interventions. Emmanuelle was a different type too. She never lacks energy. I don't know why she never runs out of energy. This is very helpful, and she's very happy-go-lucky. And she's a great partner, let's say, very dynamic. This helped us, but she found it hard at some point to leave school, leave her children, leave her friends behind, and go through interventions that were sometimes painful. Fortunately, she always said she was looking forward to go to the children. Sorry, I'm a bit emotional right now. Can you continue? Well, I guess the bar is set pretty high. She was pretty good. I'll talk about side effects and improvements we've seen. Since the beginning of the administration of that drug, Emmanuelle did not have a lot of important side effects linked to medication and the way it was injected. She felt localized pain at the injection site. Emmanuelle received her 5th injection, and since the 4th one, we see a gradual increase in her muscular tone. Her pulmonary peak has improved. She maintains her head more solidly. She's more stable when sitting, writes faster, almost as fast as another as her schoolmates. She can take the lids off bottles and the caps off her pencils, which gives her more autonomy, and she feels more proud. When she swims, her limbs are faster and she has more stamina. With the weight gain and going up, children with this disease lose capacity over time. What Dr. Chrestian mentioned is that the evolution of this disease naturally is not what it should be, usually. Emmanuelle is not losing a lot of capacity and is always gaining little by little every day. Little gains that are observed in the everyday life, and we hope that it's only the beginning. To have a sick child is not an easy situation. It represents a lot of stress, energy, and tension. There are only 24 hours in a day, and rarely do we have time to go through daily tasks and for everything to take care of our little daughter. She needs at least 3 hours of care per day: physical therapy, occupational therapy, respiration, breathing exercises, sitting exercises, and flexibility exercises. This adds up to the daily life, the eating, bathing, dressing up, etc. Our daughter has little autonomy, and this is how and where parents come into play. Days are very busy, and we try to make up for what we could not do during our days off. That means little time off, little time to rest, stress, and when you cannot do everything, sometimes feelings of guilt. Also, unfortunately, we don't know many other families with a sick child who has a lot of support and time for respite. And it's even worse, we think, in the area. As parents, we need to be a strong team for Emmanuelle to receive proper care. Support from professionals is crucial because oftentimes we feel overwhelmed. From simple parents, we become physical therapists, inhalation therapists, and occupational therapists, physical therapists, etc., etc. Without professionals with you, it would be impossible. Now, the hope we had of a better life is something that is more tangible. At the beginning, when we saw the diagnosis, the future was bleak, but the neuro specialist at the time told us to wait and bet and hope for the best thing for daughter to do exercises. And yes, we did a lot of exercises with a glass of wine Friday night, a lot of exercises. And before going to school, a lot of exercises. We never lost hope. So in spite of tiredness, fatigue, feeling like giving up, we did exercises all the time. With the efficiency of Spinoza, health professionals we meet, they talk about future and progress for those affected by spinal amyotrophy. We think that for as parents, it is only the beginning and that one day it will be cured. We thank you very much for your attention. And also would like to thank, as parents in this context, the Marie Enfant and Children's Hospital staff for all their support. Thank you. Thank you. If anybody has questions, you are welcome to go to the microphone because we are recording. And good morning. Thank you for your testimony. It was very incredible. Doctor, I have a question for you with regard to wearing a corset, a brace as part of SMA. Yes, brace. Well, in certain cases, will limit progression of scoliosis. However, will compress the lungs and chest cavity. I heard that you do also standing positions, so I guess it's one way to train it, but do you have any other exercises? It's a very good question. Yes, it's a matter of striking the right balance. It is definitely recommended once you're above 20 degrees to wear a brace regularly. And yes, you need also to readjust it regularly. This is why combining functional respiratory exercise tests every 6 months is important. But we are now very aggressive with wearing a brace. How long during a day? 4 to 6 hours during the day, minimum, to prevent scoliosis. But it goes with the child's tolerance also, and it can be very much adapted. Orthopedist usually takes this and manages this, but now we have a physical therapist for pediatrics, and he will be the one managing wearing the braces, because previously was not done adequately enough. I'm a physical therapist, and I wanted to know, as part of ASM, so maybe you could say that having in standing positions could be good. Yes, it's essential rather. For standing is essential for mobility, contractions, and honestly, it's one of the most important challenge. One of my patients was a type 3, however, was able to maintain his standing position but wanted to let go. And I said, no, Nelsie Nursen is coming in, don't give up, and she did it, and it helped her maintaining gains. But starting from the moment we faced the current problem was she let it go, because it's very demanding. It demands a lot of energy to stand for children, and you don't necessarily tolerate this for long, even if we try to do a couple hours or in slices of half hours. It's after a while we lose them, but we try to focus on scoliosis. I like Joël and Genevieve's testimony. As for most neurologists, I say good luck, try to do exercises, and obviously it's all about, there's a lot of support needed from home care, and right now There's a lot of focus in Quebec on this because we cannot provide adequate home care for these patients. Once again, in prevention of contractures and deformations. So it would be a big mass of the big part of the budget. But we need to think about this early, because with all therapies that are coming up, we will solve a lot of problems, but maybe not all of them. Or we will try to ensure that they do not develop comorbidity associated with it. Thank you. More of an ethical question here, devil's advocate here. We heard a great testimony. Children, parents who invested a lot in research, but in the end are facing the possibility of maybe not having access to that drug anymore. So upstream, should we maybe assess costs? What I hear through this is that it's a social and economic reason, but upstream, should we assess costs of this? I don't know if you understand my question. So right away, should we assess costs and saying research is great, but in the end, you will not receive that treatment anyway? Currently, we have 5 years of guaranteed medication post-study until something happens for the rest of families, because I hope so much, but really have it for 5 years. We're already guaranteed. We have only 5 years guaranteed if medication works, of course. We talked about costs. What's worth mentioning is we need to think that with this medication, children will go through fewer hospital stays, and there's also other costs that will be lowered. We were transferred last year in plane to Montreal, so there are related costs that are very high. This winter, pneumonia. She went through a fantastic winter. That's the important part here. One problem with the INR, they wanted these pharmacoeconomic data, because for a product with a significant cost for an orphan disease that is not so orphan with the data that are presented to you, well, it depends how we see it. And that is a good question, because it even is a division within our neuropediatrics community. We are even argued on an editorial I wanted to publish lately. Some wanted to be recommendations by the book with studies that had the most essential data, saying that type 1s should be refunded, and then type 2s, well, they're not enough clear-cut data. And of course we are in somewhat of a specific ethical landscape in that case, and it depends which side you take. Are you a doctor? Are you managers, administrators? And it's hard to really separate ourselves from this. Right now, clearly, I am very uncomfortable in that situation. The way that things are working currently is that a young adult, teenager, would eventually have it, receive it. But however, children I see every day cannot get it. So we can talk about parents who can receive it, but they have about 10 years of delay of the disease, but it'll take even more time to see gains. But while children like Joël and Geneviève, whose gains are very small at the beginning, but are still present, and over years, gains will be more and more significant. And that is why type 1's gains are significant, because there is a link to neuromuscular junction, and a dead nerve takes 1 millimeter to regrow. So every day, 1 millimeter. So of course it takes a year before you see something happening. If we talk about someone who has more of about a 10-year development of the disease with muscular atrophy, with fat replacement, adipose replacement, well, I have little chances. I met with a 43-year-old with type 3 spinal dystrophy, and she is in a wheelchair and moves on the right, and the neuro specialist wanted to tell her, well, even if she received the drug, she would not see any difference until she passes away. And sometimes it's about maybe you should put all our efforts and realize that it's indicated for all types of spinal amyotrophy, but maybe we should target people with the most gains possible. And I feel very, it's very ambiguous as a position to choose for one and not the other. I'll take one last question for time purposes, and if there's other questions, well then, you may go up after this presentation and talk with the presenters. Thank you very much for your presentation. I'm also a physical therapist, and I thought it was very interesting what you just shared with us. My question now, with regard to Cineraza, is there anything coming up so that instead of being an intrathecal injection, there's another mode that is easier to administer? Well, that's a very good question now. And it's a question of saying, yeah, there's lots of things coming up. Oh, that's fish, sand fish, wild fish. It's the same principle, action principle, but through the mouth, oral administration. So phase 2, phase 3 trials right now, we await them eagerly, and that's why I tend to want elsunersen to be given so that they do not lose any gains until they transfer to another more easily accessible molecule. Joël and Genevieve's testimony I thought was perfect, because they said we lost 18 months because we were in the placebo trial. What a catastrophe! But then, you know what? We're part of the lucky ones who are receiving the treatment until eventually there's another oral medication that comes up. That is the current issue. What is even more frustrating is that in other countries in the world, it was not even discussion. Whether it is France, the US, Spain, most of European countries gave it elsunersen an injection. In Canada, we have this somewhat defensive position because it's a gateway to a first significant therapies of that kind. The next ones, such as Duchenne dystrophy, well, this door will be open. We cannot close it after. And so I think there was a lot of protectionism as part of that decision.